Good morning and welcome to Patho. Today we'll be discussing Chapter 12, Cardiovascular System Disorders. The cardiovascular system has its own function, however, it interacts with all other body systems. A problem originating in the cardiovascular system can affect any other system. An example of such a problem is hypertension. Often referred to as high blood pressure, hypertension has dramatic, wide-ranging effects that include heart attacks or strokes, aneurysms, kidney dysfunction, eye damage leading to vision loss, metabolic problems that can lead to anemia, trouble with memory or understanding, dementia. Now, remember, when we talk about things like blood pressure, we talked about how that affects your vessels, right? And also diabetes, how that affects your vessels. And when you talk about the vessels that are going to, especially the eyes and the kidneys, those are very small, fragile vessels. So little effects on them can make big things happen and lead to complications. So this is why you see complications with people with both of those conditions with their eyes and with those kidneys. But also the brain, right? We got a lot of small vessels in the brain as well, and other things can affect that function. So the heart acts as a pump. It circulates blood in the pulmonary and systemic circulation system. There's three main types of blood vessels in the body: the arteries, the veins, and the capillaries. Arteries and veins help make the function of the heart possible. There has to be some way for the blood to get from one place to another, and that's what these blood vessels do. There are four main blood vessels: two arteries, two veins that are connected to the heart and its function. They include the vena cava, which is the large vein that brings blood into the right atrium of the heart, and it's divided into the superior, which is on the top, inferior, and the bottom. It carries that deoxygenated blood. The pulmonary artery runs from the right ventricle to the lungs, and at the opening of that pulmonary artery is the pulmonary semilunar valve. It also carries deoxygenated blood. Remember, this is the only artery in the body that carries deoxygenated blood. All the rest of the arteries carry oxygenated blood. Next, we have the pulmonary vein. This is located between the lungs and the left atrium, and it carries newly oxygenated blood from the lungs to the left atrium. Remember that the pulmonary vein is the only vein in the body that carries oxygenated blood. The rest of your veins carry deoxygenated blood. The aorta is the largest artery in the body. It carries oxygenated blood from the left ventricle to your body. The aortic semilunar valve is located at the entrance of the aorta. Blood itself is a fluid tissue, and the major types of cells that circulate in the blood are red blood cells or erythrocytes, white blood cells or leukocytes, and platelets or thrombocytes. The major function of blood includes transportation of oxygen, nutrients, removal of waste, protecting the body through the immune system, and helping the body to maintain a stable environment or homeostasis. Remember that the heart is a pump, so when it's not functioning well, like in congestive heart failure, it's not pumping that blood out to the body well. The same is true for arrhythmias because we don't have a full action occurring there. There's disruption. Blood flows through the pulmonary artery to the lungs where it picks up the oxygen and then it goes into those pulmonary veins on its way back to the left atrium. The left atrium is relaxed and it fills with oxygenated blood. Once it's full, it's able to contract, forcing the bicuspid valve to open, and that allows blood to flow into the left ventricle. When the left ventricle is full, the bicuspid valve will close and the left ventricle will contract and force the aortic semilunar valve to open, and that allows the blood to flow into the aorta and out to the body. Now we're going to talk about normal blood flow through the heart. The two major veins that bring blood To the right side of the heart are the superior and inferior vena cava. This is the deoxygenated blood. This blood enters the right atrium and then the right ventricle. From the right ventricle, the blood is pumped into the pulmonary artery. That artery carries deoxygenated blood. I would know that. The blood then goes to the lungs where it is oxygenated. Next, the pulmonary veins carry the oxygenated blood. It goes to the left atrium, then to the left ventricle, which is the big bad pump. Then it is pumped into the aorta, and finally this oxygenated blood is delivered throughout the body through the arterial system, where it eventually ties back into the venous system. Your heart is located between your lungs in the middle of your chest in the mediastinum. Enclosed in a double-wall pericardial sac, the outer pericardium anchors the heart to the diaphragm. The outermost layer of the heart is the epicardium. It helps protect the heart from damage. It has fluid on its surface that help reduce friction and lubricates the heart to allow movement and to reduce friction between the pericardial membranes. It's composed of elastic-like tissue that allows it to stretch as the heart contracts. This layer of the heart also has the blood vessels to supply oxygen to the heart muscle itself so it can function. The middle layer of the heart is known as the myocardium. It's that muscular layer of the heart responsible for heart contractions. It's made of specialized cardiac muscle that contract rhythmically and forcefully pump blood throughout the organs. The innermost layer of the heart is the endocardium that covers the inside surface of the chambers of the heart and the valves, protecting the inside surface of the heart, allowing a smooth surface and easier blood flow through the heart. It also forms the four heart valves that separate the chambers of the heart and ensure that one-way flow of blood. The left ventricular wall is thicker than the rest, and this is because that muscle is working harder to eject that blood into the circulation system. AV valves separate the atria from the ventricles. On the right side, and I remember this because my right side is my stronger side, so that's where I have that tricuspid valve with those three leaflets or cusps that opens and closes to allow fluid to flow through it or to stop from flowing. When the right atrium fills with blood, the valve is closed. Once the right atrium is full and ready to contract, the tricuspid valve opens, allowing blood to flow through it. On the left side, which is my weaker side, is my bicuspid valve. Sometimes they call this a mitral valve, right? Because, nursing has to have two names for everything. The bicuspid valve has two leaflets, and I remember two because it's on my left side. It's my weaker side, so my bicuspid valve is on my left side, or my mitral valve, because you'll hear this interchanged a lot. You'll hear like mitral valve prolapse, and they're talking about your bicuspid valve here on your left side. The mitral valve is closed as the left atrium fills with blood. It opens when the left atrium contracts to send the blood through. The semilunar valves each have three cusps, and these include the aortic and the pulmonary valves, which are located at the exits to the large arteries from the ventricles. The pulmonary semilunar valve leads to the lungs. This valve is closed as the right ventricle fills with blood. When the right ventricle is full, the pulmonary semilunar valve opens and allows the blood to flow through. The aortic semilunar valve is connected to the aorta. The septum separates the left and the right side of the heart. The septum divides the heart into right and left sides and separates deoxygenated blood from oxygenated blood. So when you see someone with a hole in their septum or a ventral septal defect, what will happen is we have mixing of oxygenated and deoxygenated blood, and you'll see symptoms of both in the client. The function of separating the blood is important because the heart would not be able to work as efficiently if the blood were to mix. It would send blood out to the body that is only half oxygenated instead of fully oxygenated. Our heart is part of our autonomic nervous system, so it pumps continuously even though we're not consciously aware of it and we don't control it. The heart is constantly beating at a steady, reliable pace. The conduction system of the heart is vital in maintaining life and can cause severe problems if not operating properly. Any disruption in the electrical signal can lead to an abnormal rhythm or an arrhythmia. To understand how the electrical signal creates a heartbeat, the anatomy of the heart, and how blood flows through it has to be understood first. The flow of blood occurs in these steps. Deoxygenated blood comes from the vena cava entering the right atrium. At the same time, oxygenated blood comes from the lungs through those pulmonary veins entering the left atrium. The blood flows through the tricuspid valve into the right ventricle. At the same time, blood flows through the mitral valve into the left ventricle. The right ventricle then contracts, pumping blood through the pulmonary arteries, carrying that deoxygenated blood to the lungs. At the same time, the left ventricle contracts, pumping blood through the aorta to carry the oxygenated blood out to the body. Impulses to initiate cardiac contractions are conducted by specialized myocardial muscle fibers. Unique characteristics of cardiac muscle allow ions to pass from cell to cell to help rapid transmission of these impulses. All cardiac muscle can initiate impulses, but normally the conduction pathway originates at what we call the pacemaker of the heart, or our SA node, our sinoatrial node. All right, and this is located in the wall of your right atrium. So the impulse starts at that SA node, which is located in the wall of that right atrium. It generates an impulse at about 70 beats per minute. From that SA node, the impulse will then go down through the atrial conduction pathway, causing both of the atria to contract. The impulse then arrives at the AV node. Once it arrives at that AV node in the floor of the right atrium, it's going to slow down, okay? And the reason why it's going to slow down is because it needs to allow those ventricles to completely fill up. Then the impulse will continue into the ventricle through the AV bundle, the bundle of His. The bundle of His is actually a branch of nerve cells that goes from the AV node, travels down the wall between the right and left ventricles, and then splits into branches, supplying the right and left side of the heart. Then we have the Purkinje fibers. These are the last step. The terminal Purkinje network of fibers will stimulate simultaneous contraction of the two ventricles. Conduction of impulses produces a change in electrical activity that we can pick up on an EKG by attaching electrodes to different points on the body's surface. The SA node can be altered by autonomic nervous system fibers that innervate the SA node and by circulating hormones like epinephrine. As you know, that epinephrine can increase your heart rate, right? We've talked about that multiple times. The atrial contraction is represented by depolarization in the P wave. So when we look at the P waves on the EKG, we see, are there P waves present? If so, how many? If not, that can tell us something about the heart. All right. So like in AFib or a flutter, I always say the person doesn't have time to stop and pee, because in these arrhythmias, you won't see a P wave. Okay. You won't see that atrial contraction there because the heart is beating too fast. Okay. For ventricular contraction, this is shown by the large wave of depolarization in the ventricles in the QRS wave. Now, that is showing us about the ventricular, okay, every time it contracts there. This also in here in that QRS wave is the atrial repolarization, but you can't see it because it's masked by that big QRS wave. The third wave that you'll see represents the T wave, and that is repolarization of the ventricles or the recovery phase. Again, abnormal variations in that EKG are referred to as arrhythmias, and these can indicate problems such as a recent MI, systemic problems such as electrolyte imbalances, and even on these waves, like you'll see a U wave sometimes if someone has low potassium, you'll see a U wave on that EKG. You may see spiked tall waves if someone has high potassium levels. So these things can also be recognized sometimes on an EKG. Conduction of impulses produce a change in electrical activity, so we can measure that electrical activity by placing electrodes on the skin to produce an EKG. An impulse normally is generated again in that sinus node, traveling through the atria to the AV node, slowing down a little bit so the ventricles can fill, then down the bundle of the Purkinje fibers, and to the ventricular myocardium. Recording of the polarizing and repolarizing currents in the hearts with the electrodes on the surface of the body produces those characteristic waveforms that we look at down here in the picture that you see of this EKG. So again, that P wave representing atrial depolarization, right, or atrial contraction. And then you have that QRS wave, which represents that ventricular repolarization. And again, in there, in that QRS wave, is that atrial repolarization that you can't really see. And then here you see the T wave, which represents repolarization. And that's where the heart is resting and recovering before it starts another heartbeat. Your cardiac control center is located in your medulla. It controls the heart rate and the force of the contraction. And then you have receptors known as baroreceptors in the walls of the aorta and in your internal carotid arteries. And these detect changes in your blood pressure. The cardiac center then responds to those changes by stimulating the sympathetic nervous system or the parasympathetic nervous system to alter the rate and the force of the cardiac contraction as the body needs it to. Sympathetic nervous system stimulation will increase the heart rate and cause tachycardia. It'll also increase contractility. Parasympathetic stimulation by the vagus nerve slows the heart rate and leads to bradycardia. Sympathetic or beta 1 adrenergic receptors located in the heart are an important site of action for some drugs ordered, such as beta blockers. Beta blockers are able to fit the receptors and help block some of the normal sympathetic nervous system stimulation. So, like if someone had a problem with tachycardia, they might be able to give them a beta blocker and would block any increases in the heart rate and force of contractions. So we might give this to someone after the heart's been damaged so that they don't put too much work on the heart. We never want to increase the workload on the heart, especially in someone that has a damaged heart or a heart that's sick, okay, because that will cause the heart to overwork, and that is going to lead to heart failure. And usually heart failure is a chronic problem. So we just don't want to induce that in someone if we can prevent it. Factors that increase the heart rate include elevated body temperatures such as fever, increased environmental temperatures, especially when the humidity is high, exertion or exercise, especially when beginning followed by a leveling off period, smoking even one cigarette, the stress response, pregnancy, pain, medications, glycogen levels, and dehydrations. Now, when you ask me, Miss Sue, what do I need to know for this? Okay, you need to know what is broken. Okay, how does it affect my body? Okay, what am I going to see in that client? So, if a client has tachycardia, why do they have the tachycardia? What is causing it? And what are they going to look like when they have it? How about an MI? If a client is having an MI, what caused that MI? What does it look like? Okay, what are some complications and some risk factors? Those are the only things that you need to know for my patho class. Any stimulation of the sympathetic nervous system, as with stress, increases the secretion of epinephrine, and that's going to stimulate those beta receptors to increase both the heart rate and the contractility. Now, the heart system has its own oxygenation system because cardiac muscles require a constant supply of oxygenation and nutrients to do their job. But that muscle has very little storage capacity for the oxygen. Coronary arteries supply that blood to the heart muscle. The heart muscle needs this oxygen rich blood to function. Oxygen depleted blood must also be removed. The two main coronary arteries are the left main and right coronary arteries. The right and left coronary arteries branch off the aorta immediately above that aortic valve. The left main coronary artery supplies blood to the left side of the heart muscle, the left ventricle, and the atrium. The right coronary artery supplies blood to the right ventricle, the right atrium, the SA and AV nodes, which regulate that heart rhythm. So again, that right coronary artery is also supplying that SA node and that AV nodes. Remember, that's your conduction system. So a problem with blood there, okay, this is why I'm specifying that, all right? How's that going to affect the heart? The left main coronary artery divides into branches. The left anterior descending artery branches off the left coronary artery, following the anterior sulcus or the groove down over the surface of the heart, supplying blood to the front left side of the heart. We call that the widowmaker, the LAD. Okay, a lot of people that have heart attacks there die. Now, we've gotten better with treating heart attacks, so time and everything is precious. The circumflex artery, okay, circumflex, this means it wraps around, so that encircles the heart, okay, and it supplies blood to the outer surface and the back of the heart. The right coronary artery follows the right AV sulcus on the posterior surface of the heart and branches into the right marginal artery and the posterior interventricular artery, descending in the posterior interventricular groove towards the apex of the heart. And it comes close to the terminal point of the left anterior descending. So together with the left anterior descending, the right coronary artery supplies blood to the middle or the septum of the heart. That's what you really need to know there. Okay, so that left anterior descending artery and that right coronary artery are going to supply blood to that middle or that septum part of the heart. Okay, the passage of the arteries over the surface in those grooves is helpful because when someone needs surgery, all right, we can do a bypass there. Remember, when we do a bypass, we use sections of other veins or arteries because the section that's there is necrotic. It's not going to work. Remember, when it's necrotic, once they've had that MI or once that tissue has died there, it'll become unfunctional or non-functional because of that fibroid tissues and other things that develops there, okay? So we'll take a vessel from your leg or some other part of the body and we'll create a bypass where we go around that area. The right coronary artery divides into smaller branches, okay? The posterior descending artery and the acute marginal artery. And these supply the myocardium and the endocardium. Blood flow through the myocardium is greatest. I would know this, okay? Blood flow through the myocardium is greatest during diastole or relaxation. So diastole and relaxation are the same. And this is when the blood is going to be greatest coming through that myocardium. It's reduced during systole, okay? Because during systole, the heart is contracting. So during systole, we're going to have less blood as the muscle compresses the arteries. If we have too many contractions, or if they're rapid or prolonged, this can reduce blood supply to the cardiac cells. Now, anastomosis or direct connections exist between these small branches in those left and right coronary arteries near the apex. And this is important, okay, because these junctions have the potential to open up and provide another source of blood to an area if an infarction should occur. This is how collateral circulation is developed. Collateral circulation is an alternative source of blood and nutrients, and it's important if the artery becomes obstructed for any reason. Collateral circulation is your body's way of working around the blockage. The blood vessels in your body that can take over when another artery or vein becomes blocked or damaged. Collateral circulation provides this alternative route for blood flow, but it's limited and it's not foolproof. Okay, but it can help prevent damage. People that have good collateral circulation are usually people that exercise and take good care of their health. When an obstruction develops slowly, more capillaries from the surrounding arteries tend to enlarge or extend into the adjacent tissue to meet metabolic needs of the cells. Regular aerobic exercise helps contribute to cardiovascular fitness, stimulating development of collateral channels. Any interference with blood flow can affect the function of the heart. Now, the right coronary artery supplies the right side of the heart, the inferior portion of the left ventricle, as well as the posterior interventricular septum. The left anterior descending artery brings blood into the anterior wall of the ventricles, the anterior septum, the bundle branches, and the circumflex artery nourishes the left atrium, the lateral and the posterior walls of the left ventricle. Blood sources for the SA node depend on specific position of the arteries, and that can vary in different people. The SA node is supplied by the right coronary artery in more than half of the population. However, the other half of the population, the SA node is supplied by the left circumflex artery. The AV node is nourished primarily by the right coronary artery, and that implies that blockage of the right coronary artery would likely result in a conduction disturbance of the AV node and an arrhythmia, whereas interference with blood supply to the left coronary artery would likely cause a problem with pumping ability of the left ventricle, leading to congestive heart failure. So let me just review that again, all right? I would know this, okay? The SA node is supplied by the right coronary artery in more than half of the population, but by the left circumflex artery in the rest. The AV node is nourished primarily by the right coronary artery. Since the AV node is nourished mostly by that right coronary artery, this means that blockage of the right coronary artery, which is supplying blood to that AV node, would likely result in a conduction disturbance of that AV node and cause an arrhythmia. Whereas any interference with blood being supplied by the left coronary artery would likely impair the pumping ability of the left ventricle and cause the person to develop congestive heart failure. The course of the coronary or cardiac veins generally parallels that of the arteries, with the majority of blood returning to the coronary sinus and emptying directly into that right atrium. All right, for the next 3 slides, I'd like you just to review these, okay, and see if you can, do this on your own. And then, first one is going to ask you to predict 3 ways that cardiac function could be impaired, okay? And then on the next slide, I'll help you along there to see if you were able to get it right, okay? So here's your answers here, all right? Hopefully you paused before you came to this slide And now you're looking to see, hey, is that what, I thought about? And here, I'm just asking you some questions about collateral circulation, okay? And again, um, providing some answers here for you. Hopefully you think about this, okay? And then go to the next slide. So this can kind of help you put two and two together about how this is all working. All right, and then here we discuss the answers for these questions. Your cardiac cycle is the period between the start of one heartbeat and the start of another. It has alternating phases of relaxation known as diastole and contraction known as systole. This is coordinated by the conduction system for maximum efficiency. Each cycle begins with the atria relaxed, filling with blood from the inferior and superior vena cava into that right atrium and from the pulmonary veins into the left atrium. The flow of blood through the heart follows the principle that fluids will naturally flow from an area of high pressure to an area of low pressure. During the cardiac cycle, the pressure in a heart chamber increases during systole and decreases during diastole. Blood flows from the atria to the ventricles or from the ventricles to the artery only when the pressure in the first chamber is greater than pressure in the receiving chamber or the artery. The pressure of the blood in the atria will increase, forcing the AV valves open and the ventricles are relaxed. Blood then flows into the ventricles, almost emptying the atria. The conduction system then stimulates the atrial muscle to contract and force any remaining blood into the ventricles. The atria relax. The two ventricles begin to contract and pressure increases in the ventricles. The AV valves are forced open. For a brief moment, all valves are closed. The ventricular myocardium continues to contract, building up pressure in what we call an isovolumetric phase, where there's no change in the blood volume in the ventricles. The semilunar valves will then open due to this increase in pressure. Blood is forced into the pulmonary artery and the aorta. Muscle contractions must be strong enough to overcome the opposing pressure in the artery to force the valve open. In the left ventricle, pressure must be greater than the diastolic pressure in the aorta. Because pulmonary circulation is a low pressure system, the right ventricle does not have to exert as much pressure to pump blood into that pulmonary circulation. At the end of the cycle, the atria begin to fill again, the ventricles relax, the aortic and the pulmonary valves close to prevent backflow of blood, and the cycle repeats itself. The same volume of blood is pumped from both the left and the right side of the heart during each cycle. And this is important to ensure that blood flow through systemic and pulmonary circulation is consistently balanced. So here again, we look at the cardiac cycle. So in diastole, the atria fill and all of our valves are closed. The pressure, the atrial pressure will increase, and that is going to force the AV valves to open. The ventricles begin to fill. Then systole begins. The atria contract because they're now almost empty, right? So they contract and fully empty, and the ventricles are now full. The ventricles begin to contract. The pressure closes the AV valves. The atria start to relax. The ventricles then contract. There's increased pressure in the ventricles. The aortic and the pulmonary valves are forced open. Blood is ejected into the aorta and the pulmonary artery. And then we go back into diastole. The ventricles empty. The ventricles relax. The aortic and the pulmonary valves close. And then the cycle starts all over again. The atrial start to fill back up again. So as you're listening to the heart sounds with your stethoscope, okay, you understand that these vibrations are being caused by the closure of your valves. So closure of the AV valves will cause that lub sound, followed by a dub sound, as with the closure of the semilunar valves, okay, in ventricular diastole. So we have closure of the AV valves for the lub sound, and closure of the semilunar valves for the dub sound. Murmurs are formed by defective valves that leak or do not open completely, and this causes a sound of turbulence in the blood flow or a swishing type of sound. A hole in the heart septum can also cause abnormal blood flow and cause a heart murmur. Murmurs are often caused by these incompetent valves. A weak or irregular pulse often indicates a problem. The apical pulse refers to the rate measured at the heart rate itself. A pulse deficit refers to a difference in the rate between the apical pulse and the radial pulse. Remember, you're always supposed to be checking between those two and also to both sides, and upper versus lower. There are several places on the body where it's possible to feel the pulse. These are called pulse points. Once you find the pulse, then you assess it for the following characteristics. A normal rate for an adult should be between 60 and 100 per minute. However, it can vary with person to person. Like with someone who's very athletic, we might see a little bit lower pulse. Or if someone has a thyroid issue, especially hyperthyroid, okay, it's going to be higher. Lower hypothyroid is going to be lower. We look for rhythms. Patients without underlying arrhythmias should have a regular pulse. We look for symmetry. The pulse strength should be equal bilaterally. We look at contour. The pulse should feel smooth and wave-like. And then we look at strength. Normal pulses should be easily felt with gentle palpation. Possible causes of stronger than normal pulses, or what we call a bounding pulse, would include anxiety, fever, hyperthyroidism, fluid volume overload. Weaker pulses could include poor perfusion to the extremities, such as shock or dehydration. Cardiac function can be measured in a few ways. Cardiac output is the volume of blood ejected by the ventricle in 1 minute, and it depends on the heart rate and the stroke volume. The volume pumped from one ventricle in one contraction. At rest, the heart is able to pump into the system an equal amount to the total blood volume in the body every minute. When necessary, the normal heart can increase its usual output by 4 or 5 times the minimum volume. Stroke volume can vary with sympathetic stimulation and venous return. When an increased amount of blood returns to the heart, such as in exercise, the heart is stretched more. The force of contraction increases proportionately. During exercise, stress, or infection, cardiac output can increase considerably. Now, the next terms I would know. Preload is the amount of blood delivered or returned to the heart by venous return. Afterload is the force required to eject the blood from the ventricles, and this is determined by the peripheral resistance to the opening of the semilunar valves. For example, afterload is increased by a high diastolic pressure resulting from excessive vasoconstriction. Blood pressure refers to the pressure of the blood against the arterial walls. Your systolic pressure, the number on top, is the pressure exerted by the blood when ejected from the left ventricle. Your diastolic pressure, or the number on the bottom, is the pressure that's sustained when your ventricles are relaxed. Blood pressure depends on and can be altered by cardiac output and peripheral resistance. Your pulse pressure is the difference between the systolic and the diastolic pressure. It's usually around 40, and different books may tell you different numbers, but the standard I think is around 40 for this. In adults, a normal pressure is commonly around 120/70 at rest. If blood blood pressure changes happen, they're usually detected by those baroreceptors that we talked about in the carotid arteries and in your vessels. And then the receptors relay that message to the vasomotor control center in the medulla to adjust your blood pressure. For example, if you get up from a supine position, your blood pressure will drop momentarily because of gravity, and then your reflex vasoconstriction mechanism will eventually kick in to make sure that the blood continues to flow to the brain and that enough blood or a little bit more blood goes there, okay? Blood pressure is elevated by increased sympathetic nervous system stimulation in two ways. The sympathetic nervous system and epinephrine act on the beta 1 adrenergic receptors in the heart and increase both the rate and the force of contraction. Sympathetic nervous system, epinephrine, and norepinephrine will increase vasoconstriction by stimulating those alpha 1 receptors in the skin and the organs, reducing the capacity of the system and increasing the venous return. Changes in the blood pressure can occur due to specific variables such as the blood volume, the viscosity of the blood, your venous return, the rate and the force of the heart contractions, and the elasticity of the arteries. Peripheral resistance can also be altered by systemic constriction or dilation of the arterioles. Systemic or widespread vasoconstriction occurs in response to sympathetic stimulation, increasing the blood pressure. Systemic or general vasodilation causing a decrease in the blood pressure results from a reduction in sympathetic nervous system stimulation. There is no parasympathetic nervous system innervation in the blood vessels. Okay, so if your blood pressure is reduced, it's from a lack of stimulation of the sympathetic nervous system. It's not from parasympathetic nervous system stimulation. Any obstruction in the blood vessels can also increase resistance. So if you have a lot of plaque in those vessels, okay, or clot or something else that's restricting blood flow. Other hormones also contribute to control of blood pressure, such as antidiuretic hormone or ADH. This increases the amount of water reabsorbed through the kidneys, increasing the amount of blood in the system. Antidiuretic hormone, also known as vasopressin, also causes vasoconstriction. Aldosterone increases the blood, okay, by the amount of blood, by increasing reabsorption of the sodium and the water. And remember, the aldosterone is triggered by release of renin. The renin-angiotensin-aldosterone system, or that RAS system we've been talking about in the kidneys, also is an important control and compensation mechanism. And it's initiated whenever there's any decrease in renal blood flow. So remember, we talked about this a little bit, is when the blood flow going into the kidneys is decreased, okay, the heart is not pumping out enough, or for some reason not enough blood flow is getting to those kidneys, it's going to cause those kidneys to release that renin, remember? Okay, so as that renin is stimulated, that is going to activate angiotensin, and that is a vasoconstrictor. It's very powerful. It will also stimulate that aldosterone secretion. Remember, that aldosterone is going to cause them to reabsorb sodium and water, and that's going to increase the volume as well. All right, now we're going to talk about heart disorders. Some of the common heart diseases include congenital heart defects, hypertension, angina, heart attacks, cardiac arrhythmias, and congestive heart failure. It's a major cause of morbidity and mortality. There are a few tools that we use to determine the cardiovascular function, okay, an EKG, which helps us look at arrhythmias, myocardial infarctions, infection, and pericarditis. It also can help us look at electrolyte abnormalities. It's non-invasive. It tells us about the conduction activity of the heart, okay? And again, it can also tell us about electrolyte imbalances. People can do a regular EKG, or they can wear a portable EKG or a Holter monitor. And these can be on for a day, like 24 hours, or they can leave it on for a couple of weeks sometimes. And they just look at the person's EKG over time. Also, there's buttons on there that they can record, and buttons that they can push for an emergency should a specific heart arrhythmia develop. A recording of the heart sound can also be made through echocardiography, ultrasound, and that helps record the image of the heart valve movements, the ejection fraction, provides information about valve abnormalities or valve defects, congenital defects, changes in any of the heart structure or the function. There's also stress tests that can be conducted, exercise stress tests, or they can use medications, okay? And these help us determine blockages in the heart, cardiovascular function, any exercise-induced problems like arrhythmias. So again, they can do this with medication, or they can actually have the person do this on their own on a treadmill or something in the doctor's office. Other things are x-rays that look at the size and the shape and the position of the heart. It can tell us also about any pulmonary congestion, like in heart failure. We can use nuclear imaging with thallium to look at infarcts in the heart, myocardial perfusion, function of the ventricles, and then tomographic studies that help us look at the tissue. Okay, these studies can help us identify whether there's any dead or damaged myocardial tissue and how bad that the damage is after someone had like a heart attack. There's also SPECT scans, CTs that help accurately assess cardiac ischemia in a person at rest. And then we have cardiac catheterization, which can look at the blood vessels, okay, to see if they're functioning right. It can visualize the inside of the heart, measure pressure, assess heart and valve function. And then blood flow in the coronary arteries can be looked at with coronary angiography. Obstructions can be assessed and treated with catheterization. We can use injected thrombolytic agents and laser therapy to break down any clots. We can use balloon angioplasty to narrow a coronary artery mechanically. Now remember, when it comes to TPA and breaking down clots and things of that nature, everything is time sensitive. We can also perform Doppler studies to look at the blood flow in the peripheral vessels. These record the sounds of the blood flow. We can also use blood tests to look at triglyceride, cholesterol levels, blood tests to look at sodium, potassium, calcium levels, and other electrolytes, hemoglobin, hematocrit, and blood cell counts, as well as differential counts for white blood cells. We can use ABGs. These can help check oxygenation level, acid-base balances, especially those might be considered in a client with shock or post-heart attack or MI, myocardial infarction. I'm not going to talk about treatment too much. I would review this. It's something you should know as a nurse. But again, for my pathophysiology class, they are not going to test you on treatments. Remember, follow your concept map. What is broken? Okay. What is broken? What is it causing? What does it look like? What are the symptoms? What are the risk factors? What are the complications of it being broken? Again, a few more medications here. Okay, what do they do? How do they help the body? Things you should know as a nurse. We talked about a couple of these when we were talking about how they work in the body as far as attaching to the receptors and all. But you should be, familiar with them. But they will not be being tested on. Okay, you're not going to be tested on these or Miss Sue's class for patho. Just know him as a nurse. Again, a few more cardiac meds and how they work in the body. What do they act on? What do they do? Lots of cardiac drugs, okay? Lots of them. You should know them. You should be familiar with them, but you will not be tested on them for patho. And then they put everything in a slide for you as well, okay? To show you the drugs. What are they used for? What are the side effects? Again, not tested on for patho for Jersey College. Coronary artery disease, ischemic heart disease, and acute coronary syndrome. So coronary artery disease includes angina pectoris, temporary cardiac ischemia, MIs, or heart attacks. The MIs result in damage to part of the heart muscle because of the obstruction in that coronary artery. The basic problem is lack of oxygen for the need of that heart muscle. Remember, we talked about that earlier, how those coronary arteries have to have oxygen. They don't have any storage capacity, right? Coronary artery disease can ultimately lead to heart failure, and it's one of the major causes, okay? It can also lead to arrhythmias or sudden death. Angina or chest pain occurs if there's a deficit of oxygen to the heart muscle. This can happen when the blood or oxygen supply to the myocardium is impaired for any reason. When the heart works harder than usual and needs more oxygen, or when a combination of these factors are present. The heart can adapt its blood supply to its own need through vasodilation or autoregulation unless the walls of the vessels are damaged or are not able to relax. A reduced blood supply can be caused by partial obstruction by atherosclerosis or spasms in the coronary artery. If supply and demand are only slightly balanced, an increase in cardiac demand with any physical or emotional exertion can cause a deficit of oxygen to the myocardium. Chest pain can happen in a variety of patterns. It could be classic or exertional angina, variant angina in which vasospasms occur at rest, or unstable angina, which is a more serious form. Unstable angina refers to prolonged pain at rest and of recent onset. It may be the result of a break in an atheroma. This can happen right before an MI. An atheroma or atheromatous plaque is an abnormal accumulation of material in the inner layer of the arterial wall. Most commonly, episodes of anginal pain, classic or exertional, occur when demand for oxygen increases suddenly with exertion. In most cases, there's no permanent damage to the myocardium unless the episodes are frequent, prolonged, or severe. Unlike typical angina, which is often triggered by exertion or emotional stress, variant angina or Prinzmetal's angina almost always occurs when the person is at rest. The pain from variant angina is caused by spasms in the coronary arteries that supply blood to the heart muscle. Insufficient myocardial blood supply is associated with atherosclerosis, arteriosclerosis, vasospasms, which are contractions of the arterial smooth muscle, and myocardial hypertrophy, where the heart has outgrown its blood supply. Precipitating factors of angina attacks are related to activities that increase demand on the heart, such as running up a flight of stairs, getting angry, having a respiratory infection with fever, being exposed to weather extremes, or pollution, or following the eating of a large meal. Angina occurs as recurrent, intermittent, short episodes of substernal chest pain. These are usually triggered by some physical or emotional stress, increasing the demand by the heart for oxygen. Pain is often described as tightness or pressure in the chest and radiating to the neck or the left arm. Attacks can vary in severity and last a few seconds or a few minutes. Pain is usually quickly relieved through rest and administration of coronary vasodilators such as nitro. Nitro primarily acts to reduce the systemic resistance and decreases the demand for oxygen. I would know that. You will also want to know this. Pain is described as tightness or pressure in the chest and may radiate to the neck and the left arm. Other manifestations may include the following: pallor, diaphoresis or excessive sweating, nausea. Again, attacks vary in severity and last a few seconds or a few minutes. I would know this. What's the cause of it? So if you look in example A, we have a normal oxygen supply and normal activity. And then in B, we have normal increased oxygen supply with an increase in the activity. So in a normal person, that's what happens, all right? They get the normal amount of oxygen when they're engaging in normal activity. However, when the demand increases, as in increased activity, the oxygen supply is also increased. With myocardial ischemia, we have a decreased oxygen supply, okay? We have pain. It's not meeting the demands of the body. It's not meeting the oxygen needs of the body, even with normal activity. We have a decrease in the oxygen supply and decreased activity here, okay? And then look at E, okay? Decreased oxygen supply does not meet the basic needs of the body. We have pain. All right. So just in the person trying to do normal activity, they're going to have this pain because not enough oxygen is meeting the needs or the demands of the body. So it's an imbalance there. So this is the emergency treatment for angina. Again, for this patho class, you will not be tested on treatment, but as a nurse, you should be aware. We're stopping that activity and rest. You want that patient seated in an upright position. Then you'll give that nitro or have them take that nitro sublingually, okay? Then you're checking for pulse and respiration, oxygen if needed, because you have to assess first, right? And then patient to known to have angina, you're usually going to give a second dose. Okay. Patient without a history, emergency medical aid. So you're calling 911. Now, a lot of places now are telling you to call 911 with the first dose, and that's just basically to increase survival rates. Okay, what do I need to know for this patho class? This you need to know. How does it break the body? An MI involves the death of myocardial tissue because of ischemia or deficiency of the blood. A type 1 MI occurs when a coronary artery is totally obstructed, causing prolonged ischemia and cell death or infarction of the heart wall. The most common cause is atherosclerosis with a thrombus attached. The thrombus can build up to obstruct the artery. Vasospasms can occur in the presence of a partial occlusion by an atheroma, leading to total obstruction. Part of the thrombus can break away and form an embolus or emboli that flow through the coronary artery. Most infarctions are transmural, meaning that all three layers of the heart are involved. A majority involve the critical left ventricle. Remember, that's what's pumping out to the body. That's your big bad pump. The size and the location of the infarct determine the severity of the damage. I would know this. Okay, know this. MIs are generally classified as ST elevation or non-ST elevation based on specific characteristics of the EKG. They're then further divided into 5 different types. So know these types. Type 1, primarily associated with atherosclerosis and that erythema, okay? The destruction of the cardiac muscle caused by blockage of these major arteries. Type 2 is characterized by a mismatch in myocardial oxygen supply and demand. That is not a direct result of a blockage. So the body is demanding this oxygen that's not available, okay? And it's putting this workload on the heart, all right? This increased workload. And this is what's causing the MI. Type 3 involves only fatal MIs, okay? So only those that result in death. Type 4 and 5 are attributed to MIs that occur as part of a medical procedure. So like a client comes in for a stent and they die as a result of you putting that stent in, okay, then that is going to classify as a type 4 or type 5. So this is a result of medical procedures. The functions of myocardial contractility and conduction are lost quickly as the oxygen supplies are depleted. If the blood supply can be restored in the first 20 to 30 minutes, irreversible damage may be prevented. If treatment is not instituted quickly or not effective, the area of infarction can increase. Because the myocardial fibers do not regenerate, the area of necrosis is going to be replaced by fibrous or non-functional tissue. Collateral circulation can reduce the size of the infarct. Effectiveness of collateral circulation depends on the location of the obstruction, the presence or the absence of anastomosis, and whether or not collateral circulation was established before the infarction occurred. If the infarction is a result of an embolus, then there is no opportunity for collateral channels to develop, and the infarcted area is usually going to be larger. Cardiac demand during the attack will also determine the effectiveness of the collateral circulation. I would know this, okay? Warning signs of a heart attack. These signs may be intermittent initially. Feeling of pressure, heaviness, or burning on the chest, especially with an increase in activity. Sudden shortness of breath, sweating, weakness, fatigue. Nausea, indigestion, anxiety, and fear. It's important to seek diagnosis and medical care as soon as these signs occur to prevent permanent heart damage and death. If thrombolytic therapy is administered within 20 minutes of the onset, blood flow can be restored and no permanent damage occurs in the heart. Now, this is a time thing, right? Okay. And it can only happen with certain people. Some people will be contraindicated for this. So if thrombolytic therapy is administered within 20 minutes of the onset, the blood flow can be restored and no permanent damage occurs in the heart. As the MI develops, the following manifestations become more evident, and I would notice pain. Sudden substernal chest pain that radiates to the left arm, shoulder, jaw, or neck is the hallmark of the MI. The pain is usually described as severe, steady, crushing, and no relief occurs with rest or vasodilators. In some cases, pain is not present. The client can have a silent MI or is interpreted as GI discomfort. Women often report a mild pain like indigestion, and a lot of them report things like feeling flu-like. So be very careful. Pallor, diaphoresis, nausea, dizziness and weakness, dyspnea, marked anxiety and fear, hypotension. They'll commonly have hypotension with a rapid, weak pulse because the cardiac output is decreasing and they're going into shock, cardiogenic shock, okay, because the heart's not pumping, and then low-grade fever. So this slide is showing you here the obstruction or the damage here, okay, from the thrombus in the MI. And again, here, if you look on the right, okay, you can see that we have a partial obstruction here, all right, that led to likely this MI. Okay, again, partial obstruction, atherosclerosis, number one cause, along with that erythema. Okay, some of this plaque or some of the material breaks off, all right, or it can form a blood clot and just totally here block the artery because you already have a narrow passage and now is sticking to the side there, and it forms this clot and nothing can get through. All right, here we're going to talk about diagnostically what would we see in an MI. Changes in the EKG would confirm the diagnosis and assist in the monitoring process. So again, that ST thing that we're looking at, the ST elevation, sometimes you'll have enzymes and isoenzymes are going to be released from those cells that have died there. Okay, those necrotic cells, and these will follow typical patterns. So we'll see elevations of lactic dehydrogenase or LDH1. We'll see elevations of aspartate aminotransferase. We'll see elevations of creatinine phosphokinase with M and B. So this will be listed as CKMB. We also might see LDH1 and CKMB because those are more specific for the heart tissue. All right. We'll also see levels of myosin and cardiac troponin. Now, troponin is one of your gold standards. Okay. These are going to be elevated a few hours after the MI. A rise in the cardiac troponin levels is considered most specific for myocardial tissue damage. Electrolyte levels, especially potassium and sodium, can be abnormal. Leukocytosis and an elevated CRP and erythrocyte sedimentation rate are commonly elevated, signifying inflammation in the body. High levels of CRP would indicate a more marked inflammatory response, with plaques more inclined to rupture. Thrombus would likely form, and ultimately an increased probability of a more severe heart attack. And then ABG measurements would be altered, especially if the client has shock. We would look at pulmonary artery pressures. These can help us look at ventricular function. So this slide here is just showing you after the infarction, okay? So if you look at your time frame, which one of these would be elevated and for how long, okay? When would they start to elevate? What would we see? All right, typically we look at troponins for at least 3 rounds over a 24-hour period. Troponins can stay elevated for quite a few days. All right, some of these other ones, your CPK-MB would be elevated right away, and they could remain elevated for up to almost 72 hours, you see there. So complications, sudden death right after the MI can occur, and this can be because of ventricular arrhythmias or fibrillation. All right, so VTAC or VFib. This is the major cause of death in the first hour after an MI. Heart block can also occur if the conduction fibers in the infarcted area are not able to function. An area of necrosis and inflammation outside the conduction area can stimulate more spontaneous impulses at an ectopic site. So these can cause things like PVCs that lead to VTAC or VFib. Conduction irregularities can also be precipitated by hypoxia, increased potassium being released from those dead cells, acidosis, and drug toxicities. People that use cocaine can suffer fatal heart attacks even at a young age because cocaine interferes with cardiac conduction, causing vasospasms and occlusion. Cardiogenic shock can develop if the pumping capacity of the left ventricle is impaired in any way. And then congestive heart failure is a common occurrence when the contraction ability of the ventricle is reduced and the stroke volume declines. Also, thromboembolisms can come or happen from a thrombus that develops over the infarcted surface inside the heart, known as a mural thrombus. We can have rupture of the necrotic heart tissue, especially in patients with ventricular aneurysms or those with significant hypertension. Again, for my class for patho, you're not being tested on treatments. You should know them as a nurse. The main thing we want to do is decrease the workload on the heart, okay? So that's what that's saying, reduce cardiac demand. We want to decrease the workload on the heart. That's what one of the things that nitro helps do in chest pain. It decreases the demand, okay? We're going to give oxygen, something for pain. It's very painful. Anticoagulants for those blood clots. Okay, TPA is going to be varied based on the client's time to the door. Again, they're saying 20 minutes this should be given within. But, there are specific protocols for when we give this and who we give it to. And then medication for those arrhythmias, for the hypertension, if they develop CHF, and then they're going to probably all need some sort of cardiac rehab. All right, cardiac arrhythmias, dysrhythmias, same thing, okay? These are deviations from the normal rate or rhythm, and they can happen because of damage to the conduction system or because of electrolyte disturbances. All right, other things that can cause them are fever, hypoxia, stress, infection, or toxicity from drugs. Interference with the conduction system can happen because of inflammation or scar tissue associated with rheumatic fever or a heart attack or an MI. The EKG gives us a method to monitor the conduction system and help us determine if there are any abnormalities. Arrhythmias reduce the efficiency of the heart's ability to pump. A slight increase in the heart rate increases the cardiac output, but a rapid heart rate stops the heart from being able to fill appropriately during diastole, and that reduces your cardiac output. A very slow rate also reduces output to the tissues, including the brain and the heart. Irregular contractions are inefficient because they interfere with the normal ability to fill and empty. So in order to treat these arrhythmias, again, you're not being tested on this, okay? But as a nurse, what do I need to know? Okay, we give something to try to stop it, some sort of medication, or we might have to change a drug dose if it's too much of a drug that's causing this. Okay, and then there's some antiarrhythmic drugs they can give. They could also put a pacemaker in. Again, this is a permanent pacemaker. Okay, they can put this in to try to help maintain the rate and the rhythm of the heart. First, we're going to talk about sinus node abnormalities. So remember, the SA node is that pacemaker for the heart, and its rate can be altered. Bradycardia is a regular, slow heart rate, less than 60 beats per minute. It can come from vagal nerve stimulation, parasympathetic nervous system stimulation. An exception can happen in athletes at rest. People who exercise and all often have a slow heart rate because they're conditioned. Okay. Tachycardia is a regular rapid heart rate from 100 to 160 beats per minute. It can be a normal response to sympathetic nervous system stimulation, exercise, fever, or stress, or it can be compensating for a decrease in the amount of blood or hypotension. So like in someone with shock or someone that's losing blood for any reason, the first thing that's going to happen in the body is the increase in the heart rate, not the drop in the pressure. We'll see the increase in the heart rate first. Sick sinus syndrome is a heart condition, and in these clients, we see an alternating period between bradycardia and tachycardia, and these clients often require a pacemaker. Now, look at the EKG strips below. When we look at an EKG, we look at a lot of things. We look at those little boxes that you see there, and we count those, okay, because those boxes tell us about time. Also, if you look at the normal EKG, you'll see a P wave, you'll see a QRS wave, and then you see a T wave. So we look at every one of these patterns to make sure that they each follow the same characteristics. So every time that you see a heartbeat there, you should see a P wave, a QRS, and a T wave. We also look at things like the P waves. Are they all alike? Are they all the same size? Are they all the same length? Is it the same in all of them from the start of that P wave to the start of that QRS wave? Is it the same length? Is that QRS wave normal? Is it the right length? Is everything the same? Does the T wave look the same? Are there any other additional things? So if you go down and look at B, right, they have the P wave there, but you really don't see a T wave there. You can see that the QRS is not the same length, okay? And also, it looks like it's a little elevated there. So we look at all those things, okay? And then remember I said in AFib and a flutter, okay, you don't have time to stop in P. So you notice that in the AFib, there's no P wave there. There's no definitive P wave. There's no definitive T wave there. Look at your VFib. Also, nothing there definitive. No QRS, no P wave. Okay, that's a very disorganized pattern. All right, and then you have premature atrial contractions, tachycardia. You won't be asked to read these, but you should know what each one of the characteristic waves represent, and you should have an idea of looking at it, what's going on with the heart here. The other thing that I would know is the difference between AFib and a flutter. Okay, what is regular sinus rate? What is sinus tachycardia? What is sinus bradycardia? All right, so A, we have a normal EKG. In B here, we have an atrioventricular node block, very slow ventricular contraction here. So here we only have about 25 to 45 beats per minute at rest. And if you look, your P waves are widely separated from the peaks of the QRS complexes. Then C is bradycardia. So that is just that slow heart rhythm of less than 60 beats per minute. We don't have any disruption of the normal pattern, meaning that we can see, all the things that we need to see in there. With tachycardia, we have this rapid heart rate, that is D, okay, and that's greater than 100 beats per minute, but there's no disruption of the normal rhythm pattern. Normal sinus rhythm, paroxysmal suddenal atrial tachycardia is happening there at the end of that slide, okay? And then E, we have premature atrial contraction. This is unexpected early P waves that differs from the normal P waves. So remember I was saying you have to look at your P waves and see if they're happening at the same spot, the same everything. Okay, and then the PR interval, which is from where that P wave starts into where that QRS clicks in. Okay, that has to be a certain time frame. I believe it's 0.12 to 0.20. So we would count the blocks there and determine if that's correct. Okay, We're looking at the QRS complex. And then F is AFib, which is showing you that irregular rapid atrial depolarization. So here the rate is going to be usually very high, okay? So I think I went over that rate somewhere. Let me look at it real quick and I will give you that. Okay, so your book lists atrial flutter as a rate of 160 to 350 beats per minute, and atrial fib with a rate of more than 350 beats per minute. Okay, so that's on page 249 in your book. Those are the rates that I would know as far as those are concerned. All right, so basically it might ask you some basic questions. It shouldn't ask you to read any EKGs, but it may ask you some basic questions about the arrhythmias. Atrial conduction abnormalities are the most common arrhythmia. Hospital admissions for paroxysmal AFib have increased primarily because of the aging population and increases in coronary heart disease. Premature atrial contractions or beats are extra contractions or ectopic beats of the atria that usually come from a focus of irritable atrial muscle cell outside the conduction pathway, and they interfere with the timing of the next beat. Ectopic beats may develop from re-entry of an impulse that has been delayed in a damaged area or damaged tissue and then completes a circuit to re-excite the same area before the next regular stimulus arises. So what this is basically saying is sometimes these arrhythmias, the impulse is generating from away from that SA node. It's not generating from the SA node. And this is why sometimes people can have a cardiac ablation. We can burn that tissue, okay, to stop that tissue from regenerating that impulse or that signal when it's damaged. Sometimes palpitations are felt and the rapid or irregular heart contractions can come from excessive caffeine intake, smoking, or stress. So the client will feel this, right? They're taking in too much caffeine or too much smoking, and all of a sudden they start to feel these palpitations. A flutter refers to an atrial heart rate, again, of 160 to 350 beats per minute, and atrial fibrillation is a rate of more than 350 beats per minute. With flutter, the AV node delays the conduction, and so the ventricular rate is slower. A pulse deficit can occur because we have a reduction in the stroke volume that is not felt at the radial pulse. Atrial fibrillation causes pooling of blood in the atria, and the formation of thrombi or clot is a risk here. All right, so with a flutter, the AV node is delaying the conduction, and so the ventricular rate is going to be a little bit slower. The pulse deficit occurs because of a reduction in the stroke volume, and so we don't feel it at the radial pulse. With AFib, this causes pooling of blood in the atria, and these people can develop blood clots as a result of that pooling of the blood. So that's why they're usually on anticoagulants. So that's the difference between those two. A lot of times they will ask about the difference in the heart rate. I would know it. Okay, as far as heart blocks are concerned, I would know the difference between the types of heart blocks. Heart block happens when conduction is excessively delayed or stopped at the AV node or the bundle of His. Now, remember, we said that the right coronary artery supplies blood here. So think about that. Partial blocks may be as follow. First degree, in which the conduction delay prolongs the PR interval, or the time between the atrial and the ventricular contraction. So that's first degree heart block. The conduction delay prolongs the PR interval, the time between the atrial and the ventricular contraction. In second degree heart block, we have a longer delay. It leads periodically to a missed ventricular contraction. And in third degree heart block or total heart block, we have no transmission of the impulse from the atria to the ventricles. The cardiac output is greatly reduced sometimes to the point of fainting or syncope, causing a stroke Adams attack or cardiac arrest. All right, now we're talking about ventricular conduction abnormalities. And again, you need to know these. This is telling you how it's breaking the body and what will be the result. Okay, so the bundle branch block is interference with conduction in one of the bundle branches. And while it doesn't alter the cardiac output, it will show up on the EKG as a wide QRS wave or complex. In VTAC, we have a reduction in cardiac output. The filling time is greatly reduced and the force of the contraction is reduced as a result. In VFib, the muscle fibers will contract independently, and we have this uncoordinated quivering occurring rapidly. So the heart is ineffective in being able to eject the blood. There's a lack of cardiac output. That leads to severe hypoxia in the myocardium, and the contractions stop. PVCs are additional beats that come from ventricular muscle cells or ectopic pacemakers. Occasional PVCs do not interfere with the heart function, but when they increase in frequency or if we have multiple ectopic sites, they are of concern because VFib can develop and lead to cardiac arrest. Okay, I would definitely review this chart. They do like to ask questions from the chart. This chart is telling you, about the heart rate, about the effects, okay? How's it breaking the body? All right, so for arrhythmias, how are we going to treat it? Again, not something you will be tested on for this patho class for Miss Sue, but it's something you should know as a nurse. So first we have to determine the cause, okay? Anti-arrhythmia drugs, possibly. Pacemakers, okay? Maybe a conversion, defibrillators. We might have to do cardiac ablations. So there's a few ways that we can fix this. All right, cardiac arrest is cessation of all activity in the heart. We have no conduction of impulses. The EKG shows a flat line. Lack of contraction means no cardiac output. We just talked about that in VFib. Okay, and this deprives the brain and the heart of oxygen. Loss of consciousness will take place immediately and the person will stop breathing. There's no pulse at any time, including the apical and the carotid site. Arrest can occur for many reasons. For example, excessive vagal nerve stimulation can slow the heart. Drug toxicity can occur. There may be insufficient oxygen to maintain the heart tissue because of severe shock or VFib. To resuscitate a person, blood flow to the heart and the brain must be maintained. So this is why they'll tell people, if you're there and this occurs, just start CPR. Just start compressions. You don't even have to breathe into their mouth. Just start compressions because at least with that, we can keep that circulation going. In congestive heart failure, the heart is unable to pump sufficient blood to meet metabolic needs of the body. Usually, congestive heart failure is a complication of another heart or lung condition. It's usually a chronic condition involving a combination of factors. Depending on the cause, one side of the heart usually fails first, followed by the other side. For example, infarctions in the left ventricle or essential hypertension, high blood pressure, can affect the left ventricle. Pulmonary valve stenosis or pulmonary disease would affect the right ventricle first. Initially, various compensation mechanisms help maintain cardiac output. Sometimes these mechanisms can aggravate the condition instead of helping the body. Vasoconstriction or increased afterload and increased blood volume, increased preload caused by the kidneys because it is secreting that renin and that aldosterone when the body has a low outflow. okay, can add to the workload of the heart. So we talked about how in the body, whenever it recognizes that there's a low amount of blood flow going to the kidneys, it's going to start to release renin. It's going to trigger the kidneys to release renin because not enough blood flow is coming in there. So the kidneys are like, hey, bro, we're not getting enough blood here. So we need to release some renin because we need to increase the blood pressure because the body is not getting enough blood. But if the body is in heart failure, releasing that renin is going to overwork it and put an additional strain on it, okay? And the body can't process it anyway because it's not pumping effectively. So now we have the body trying to put the blood out. It can't. It's getting this increased workload because of the release of this renin and that aldosterone, and that can cause the heart to fail completely. Okay, it's adding to the workload of that heart. The sympathetic nervous system will also respond by increasing the heart rate and the peripheral resistance. The increased heart rate can decrease the efficiency of the heart, impede its ability to fill, and increase the work for the heart. The chambers of the heart will dilate or enlarge, and the cardiac muscle will become hypertrophied, known as cardiomegaly. The wall of the ventricle eventually becomes thicker because it's working harder here. This process demands an increase in blood supply to the myocardium itself because now the myocardium is working harder, so it needs an increase in blood supply because it needs more oxygenation. Some of those myocardial cells are going to die, and of course, when those cells die, right, they can no longer auto work, and they're going to be replaced with fibrous tissue. So now we have cells here that aren't working in the heart. When the heart is not able to pump efficiently, the cardiac output or stroke volume decreases, so less blood is going out to the organs and the tissues. This causes a decrease in the cell function. The person becomes fatigued and lethargic. They start to develop acidosis because they're retaining carbon dioxide. The body will eventually increase the respirations to compensate, and the affected ventricle cannot pump the load adequately. Return of the blood to that side of the heart is also impaired. This is called a forward effect, and I would know the difference between the forward and the backward effects. Backup congestion develops in circulation behind the ventricle that is affected. The output from the ventricle is less than the inflow of the blood. For example, if the left ventricle is not able to pump all of its blood into the circulation system, the normal volume of blood returning from the lungs cannot re-enter the left side of the heart. This causes congestion in the pulmonary circulation, increased capillary pressure, and possibly pulmonary edema, in which fluid is now forced into the alveoli. This situation is known as left-sided congestive heart failure. In right-sided congestive heart failure, the right ventricle cannot maintain the output. So less blood goes out to the left side of the heart and systemic circulation, known as a forward effect. The congestion is apparent in the systemic circulation as seen by increased blood volume and congestion in the legs and the feet, and eventually also in that portal circulation, liver and digestive tract, so that ascites we see in that abdominal area, and then you'll see those distended neck veins as well here. So if we look at this slide here, you see the left ventricle is weak here and it's not able to completely empty. Okay, that causes a decrease in cardiac output out to the body. It also causes a decrease in the blood flow to the kidneys, and that is going to stimulate the release of the renin, angiotensin, aldosterone system. Okay, so the kidneys are going to release the renin. And remember, that is going to stimulate the aldosterone. Okay, renin is going to trigger that powerful vasoconstrictor to try to bring up the blood pressure. All right, and aldosterone is going to help us reabsorb more sodium and more water so that we have more blood volume. Okay, Now we have this backup of blood into the pulmonary vein. The high pressure in the pulmonary capillaries forces the fluid into the alveoli, causing pulmonary congestion or edema. So let me just go through that again, okay? We have this infarction that impairs the pumping ability or the efficiency of our conduction system, or some sort of valve change, some sort of congenital heart defect that causes failure of the affected side. Why? Okay. Because of the things that we just talked about. So we have a left or damaged area there, okay? It's causing a decrease in the output. That decrease in the output, especially to the kidneys, causes that renin and that aldosterone to be released. That's going to cause the backup of the blood into the pulmonary veins, leading to a high pressure leakage into the alveoli and pulmonary congestion. Coronary artery disease is currently the leading cause of congestive heart failure. Essential hypertension can increase diastolic blood pressure and require the left ventricle to contract with more force to open the aortic valve and eject the blood into the aortic. That can cause the left ventricle to hypertrophy and fail. So a lot of different things can happen here. So here now we're talking about pulmonary disease. Okay, so here the right ventricle weakens; it's not able to empty. That causes a decrease in the cardiac output to the body. The decrease in that cardiac output results in low blood flow coming into those kidneys. Okay, so we have a decrease in the renal blood flow. Again, that's going to stimulate that renin, angiotensin, right, vasoconstrictor, and that aldosterone. That is going to cause us to reabsorb more sodium and water. That is going to cause a backup of blood into the vena cava or our systemic circulation system. The increase in that venous pressure is going to result in edema to the legs, the liver, and the abdominal organs. And then if it's very high, the venous pressure can cause distended neck veins and cerebral edema. So in pulmonary disease, this damages the lung capillaries. It increases pulmonary resistance, and it increases the workload for the right ventricle. This causes the right ventricle to hypertrophy, and it can eventually fail. Right-sided congestive heart failure because of pulmonary disease is often referred to as cor pulmonale. So now I should know these, okay? Because this is what they're going to test me on. Signs and symptoms become marked as the condition progresses. So increase in risk of sudden death from congestive heart failure. With failure of either side, forward effects are similar. So forward effects are going to be a decreased blood supply to the tissue, resulting in general hypoxia, fatigue and weakness, dyspnea, breathlessness, shortness of breath, especially with exertion, exercise intolerance, cold intolerance, and dizziness. The body will try to compensate, and so the client will develop tachycardia, pallor, and daytime oliguria. Okay, so it's withholding fluid here, right? It's trying to conserve the fluid. Backup effects of left-sided heart failure are related to pulmonary congestion. So left equals lungs, right equals body, okay? Left-sided heart failure related to pulmonary congestion or the lungs. So we'll see things like dyspnea or shortness of breath, orthopnea or difficulty breathing when you're lying down. So they'll sit up in a recliner. Cough, commonly associated with fluid irritating the respiratory passages. Lungs become a dependent area when the body is recumbent, And so interstitial fluid returns to the blood, reducing edema but increasing the blood volume and the pooled fluid in the lungs. Paroxysmal nocturnal dyspnea can happen. This would indicate the presence of acute pulmonary edema. So as that fluid returns to the lungs during the night, because of that gravity, all right, this can happen while they're sleeping. It can come and go. They have this increased blood volume in the lungs, causing increased fluid in the alveoli, interfering with oxygen diffusion and lung expansion. So the person wakes up in a panic, struggling for air and coughing, and usually they'll produce this frothy, blood-stained sputum or hemoptysis, right? I coughed it up, mopped it up. So this blood-stained sputum they coughed up, all right, from that pulmonary edema, if the capillaries have ruptured from the pressure. Rusty colored sputum can also be present with recurrent pulmonary edema, indicating the presence of hemosiderin containing macrophages in the lungs. The client may also have rales or bubbly sounds of fluid in the lungs, a rapid, weak pulse with cool, moist skin. Excessive fluid in the lungs leads to infections such as pneumonia. These are things you should know. All right, signs and symptoms of right-sided heart failure. Other things you should know, and systemic backup. So dependent edema in the feet or the legs or areas such as the buttocks. Remember I said in that sacral area when they're laying down. Hepatomegaly, splenomegaly, so enlargement of the liver and the spleen. Okay, and that is ascites you'll see here. Digestive disturbances, as in the walls of the digestive tract, that can become edematous. Ascites in the peritoneal cavity, causing abdominal distension. This can lead to impaired respiration by putting pressure on the diaphragm and impairing the lung expansion. Acute right-sided failure indicated by increased pressure in the superior vena cava, resulting in a flushed or a red face, distended neck veins, headaches, and visual disturbances. This requires quick treatment, okay? Because remember that cerebral edema, and they can develop brain damage because the brain is not being perfused appropriately. Okay, I would definitely review this slide. So forward failure versus backward failure. In forward failure, we don't have enough output, okay, from the affected ventricle, and that causes a decreased perfusion. In backward failure, the blood backs up behind the ventricle, and this causes increased pressure in the atrium behind the affected ventricle. Low output versus high output. And low output failure, we don't have enough cardiac output to meet the demands on the body. In high output failure, a condition causes the heart to work harder to meet the demands of the body, like hyperthyroidism or shock. Systemic failure, diastolic failure. Systolic failure leads to problems with contraction and ejection of the blood. And then diastolic failure leads to problems with the heart relaxing and filling with blood. Again, I would look at this chart for congestive heart failure, know the difference between left-sided versus right-sided. Here you have what breaks it, okay, what it's going to cause, what are the signs and symptoms, backward, forward, and how does the body compensate. So I would know this chart. Okay, with kids, okay, kids are growing rapidly, okay, and their metabolism is highly increased, and when they're eating all that food that they need, all those nutrients is going to help them survive and get through that metabolism, that increased metabolism. So for infants and young children with heart failure, they're going to manifest a little bit differently in adults, and usually one of the first signs we see is that failure to thrive. They're not gaining weight. So heart failure for them is often going to be secondary to some sort of congenital heart disease, with feeding difficulties being the first sign. Okay, the child does not gain weight or meet those developmental guidelines. Their periods of sleep are going to be short because they usually fall asleep while they're eating, and they become irritable when they awake. There's often a cough, rapid grunting respirations, flared nostrils, and wheezing. With right-sided heart failure, we'll see enlargement of the liver or hepatomegaly and ascites. And a lot of times we'll hear a third heart sound known as a gallop. On the x-rays, okay, we'll see enlargement of the heart or cardiomegaly, the presence or absence of fluid in the lungs. Cardiac cath can be used here to monitor the hemodynamics or the pressures in the circulation system. We can also use ABGs to measure hypoxia. Cardiac anomalies are structural defects in the heart that develop during the first 8 weeks of embryonic life, and I would know that. A structure such as a valve can be altered or missing. Heart defects are the major cause of death in the first year of life. Both genetic and environmental factors contribute to congenital heart defects, and these defects often occur with other developmental problems. Congenital heart disease can include valve defects that interfere with normal flow of blood, septal defects that allow mixing of oxygenated and unoxygenated blood, shunts or abnormalities in the position or shape of the large vessels like the aorta and pulmonary artery, or a combination of these factors. Most defects are detected by the presence of heart murmurs. All significant defects will result in a decreased oxygen supply to the tissue unless adequate compensation is available. If untreated, the child may develop heart failure. There are different methods of classifying the defects using either the type of defect or the presence of cyanosis. Many variations and degrees of severity are possible with these defects. The child may be cyanotic or acyanotic depending on the direction of the shunting. For example, if the child has a left to right shunt, the blood from the left side of the heart is recycled to the right side of the heart and the lungs, and this causes an increased volume in pulmonary circulation and a decrease in cardiac output, and therefore an inefficient system. However, with a right to left shunt, the child will have unoxygenated blood from the right side of the heart bypassing the lungs and directly entering the left side of the heart. The direction and the amount of the abnormal blood flow would determine the effects on that child. Acyanotic conditions are disorders where the systemic blood flow has oxygenated blood, although the amount may be reduced. In a cyanotic disorder, the blood from the veins mixes with the blood from the arteries, allowing significant amounts of unoxygenated hemoglobin in the blood to bypass the lung and enter circulation. The high proportion of unoxygenated blood produces a blue color characteristic of cyanosis in the skin and the mucous membranes, especially the lips and the nails. Most defects appear to be multifactorial and reflect a combination of genetic and environmental influences. These defects are often associated with chromosome abnormalities like Down syndrome. Environmental factors include viral infections such as rubella, maternal alcoholism or fetal alcohol syndrome, and maternal diabetes. Using the sympathetic nervous system, the heart increases the rate and force of contraction in an effort to increase cardiac output. This response increases the oxygen demand in the heart, restricts coronary perfusion, and increases peripheral resistance. This causes the heart to dilate and become hypertrophied. This response is ineffective because of the defect in the heart itself. Respiratory rates can increase if the oxygen deficit causes acidosis because of increased lactic acid in the body, but oxygen levels have to drop considerably before this factor influences the respiratory rate. Secondary polycythemia can develop with chronic hypoxia as erythropoietin secretion increases as compensation. So this is kind of like what we talked about in COPD, where the body recognizes that it doesn't have enough oxygen or hemoglobin, so it starts producing these additional red blood cells trying to fix itself. Small defects are often asymptomatic other than the presence of a heart murmur. A large defect can lead to the following: pallor and cyanosis, tachycardia with a rapid sleeping pulse and frequently a pulse deficit, dyspnea or shortness of breath on exertion, and tachypnea, in which the signs of heart failure are often present. A squatting position, we see this in toddlers that have tetralogy of Fallot, and this is often seen in toddlers or older children, and it appears to modify the blood flow and help to be more comfortable for them. Club fingers, thick or bulbous fingertips, and these take a long time to develop. A marked intolerance for exercise and exposure to cold weather, and then delayed growth and development. Diagnostically, we have several techniques and modalities, both invasive and non-invasive. So cardiomegaly can be seen on the X-ray, that's enlargement of the heart. We have other diagnostic imaging we can do, SPECT scans to look at functional, echocardiography, all those things we talked about earlier. Cardiac caths, echocardiograms, EKGs, and surgery. So a lot of times we'll need surgery to close, like if there's an opening between the wall, or if we need to replace the valves or parts of the vessels. Sometimes septal defects will close over time on their own. A ventricular septal defect is the most common congenital heart defect, and we call that a hole in the heart. It's usually an opening in the inner ventricular septum. It can vary in size and location. If it's small, it usually does not affect cardiac function significantly, it will increase the risk for that person to develop infective endocarditis. Septal defects can also occur in the atrial septum when the foramen ovale fails to close after birth. With a ventricular septal defect, the blood flow through the defect is usually left to right, producing an acyanotic shunt. So remember, they won't have any cyanosis here. Large openings can permit a left to right shunt of blood. The blood can flow only in one direction, from high pressure to low pressure. In this case, with that large opening, the left ventricle is going to be the high pressure area, and so the blood flows through the septal defect from the left ventricle to the right ventricle, causing less blood to leave the left ventricle. So that's going to reduce the volume of the stroke and the cardiac output out into circulation. More blood can enter the pulmonary circulation, some of which is already oxygenated, reducing the efficiency of the system and causing an overload, irreversible damage to the pulmonary blood vessels, and leading to pulmonary hypertension. This complication, which may occur in untreated ventral septal defects, would lead to abnormally high blood pressure in the right ventricle and reversal of the shunt to a right to left shunt, leading to cyanosis. Again, they're not going to test you for Ms. Sue's class on treatments. Treatments are either going to be surgical or medications, a combination of both, okay? And there's different ways we can do it. Next, we're talking about valve defects. Malformations most commonly affect the aortic and the pulmonary valve, and these problems can be classified as stenosis, which is narrowing of the valve, okay, restricting the forward flow of the blood, or valve incompetence, which is failure of the valve to close completely, which allows the blood to regurgitate or leak backward. Mitral valve or the bicuspid valve prolapse is a common occurrence. Here we have an abnormally enlarged and floppy valve leaflet, and it causes the blood to regurgitate. Valve defects reduce the efficiency of the heart pump. They reduce the stroke volume. If the opening is narrow, like in pulmonary stenosis, it makes the myocardium work harder to contract using more force. And that will cause the chamber of the heart to hypertrophy, and eventually it can cause it to fail. If the valve leaks and the blood regurgitates backward, the heart also has to increase the effort to maintain cardiac output. So again, surgical replacement through mechanical or animal or tissue valves here is likely going to happen at some point. In this slide, you can see the effects of the heart valve defects. So with normal blood flow in A, we have the blood flowing freely forward and no backflow. In stenosis, even though the blood flows through the narrowed opening, it's not flowing through well enough. But we don't have any backflow of blood. But it does make the work of the heart harder because it has to push harder to get through there or contract harder. In the incompetent valve, the blood flows forward freely, but it regurgitates backwards through that leaky valve. So again, in order to maintain cardiac output, the heart has to work harder. This slide is just showing you an image of mitral valve replacement with those potential valves that they might be able to use for a client. All right, tetralogy of Fallot is the most common cyanotic congenital heart condition here. Okay, it's more complex and serious than the others because we have 4 abnormalities here. It's considered a cyanotic disorder. Sometimes these babies are called blue babies, and I would know what these 4 defects are. All right, so we have pulmonary valve stenosis, ventral septal defects, dextroposition of the aorta. So the aorta is to the right, and it's right over that ventral septal defect. And then we have the right ventricular hypertrophy, which is usually a result of that pulmonary stenosis. The combination alters the pressure in the heart and alters the blood flow. The pulmonary valve stenosis restricts the outflow from the right ventricle, leading to right ventricular hypertrophy and high pressure in that right ventricle. Pressure in the right ventricle is now higher than pressure in the left ventricle, leading to a right to left shunt of the blood through the ventral septal defect. The flow of oxygenated blood from the right ventricle directly into systemic circulation is promoted by the position of the aorta over the septum or the ventral septal defect. This causes pulmonary circulation to receive a small amount of unoxygenated blood from the right ventricle, and systemic circulation receives a large amount of blood consisting of mixed oxygenated and unoxygenated blood. The oxygen deficit is great, and there are marked systemic effects and cyanosis. Surgery is the only effective treatment for tetralogy of Fallot, and it's usually done during the first year after birth. For these congenital heart defects, we'll talk about these a bit. A is atrial septal defect. Here, the blood flow through the defect is usually left to right, and it produces an acyanotic shunt. In B, we have a ventricular septal defect. The blood flow through the defect is usually left to right, again producing an acyanotic shunt. And then patent ductus arteriosus, where the blood flow through the ductus is usually from the aorta to the pulmonary artery, and this produces an acyanotic shunt. All right, let's look at this image. First, we have D, which is coarctation of the aorta. The arterial narrowing can produce a weaker pulse in the lower extremities, so we'll see a difference in the pressures between the upper body versus the lower body and the pulse. The tetralogy of Fallot, which we talked about, showing those 4 characteristic abnormalities, the pulmonary stenosis, which leads to that right ventricular hypertrophy, the ventricular septal defects, which allows the mixing of that oxygenated and unoxygenated blood, that overriding aorta, which also allows some of that blood to be mixed, and right ventricular hypertrophy. Tetralogy of Fallot is a cyanotic defect. So that's your blue babies, cyanotic. F is showing us transposition of the great arteries where two separate circulations are formed. This is incompatible with life unless the mixing of blood occurs between some other defect. Okay, next we'll be talking about inflammation and infection in the heart. First is rheumatic fever. This is an acute systemic inflammatory condition that appears to result from an abnormal immune reaction occurring a few weeks after an untreated infection. Okay, got to know this stuff. Usually caused by certain strains of group A beta streptococcus. All right, so what is it? How does it break the body? Okay, so acute systemic inflammatory condition, rheumatic fever. It's an abnormal immune reaction that occurs a few weeks after an untreated infection, usually by certain strains of group A beta hemolytic streptococcus. Okay, what's it going to cause? Inflammation in the heart and the joints and the skin. Usually happens in kids 5 to 15 years old. Long-term effects: rheumatic heart disease, complicated by infective endocarditis and heart failure in older adults. The antecedent or preceding infection commonly appears as an upper respiratory infection, tonsillitis, pharyngitis, or strep throat. The awareness of the risk of rheumatic fever has led to an increase in the use of rapid tests to quickly identify and treat that strep infection, since that group A streptococcus is the major cause of this rheumatic fever here and leads to rheumatic heart disease. Antibodies to the streptococcus organism form as usual. Then they react to the connective tissue and collagen in the skin, the joints, the brain, and the heart, and that causes the inflammation. The heart is the only place where scar tissue is going to develop, and this occurs causing rheumatic heart disease. During the acute stage, inflammation of the heart can involve one or more layers of the heart. With pericarditis, we have inflammation of the outer layer, and this can include an effusion or excessive fluid accumulation, impairing the heart's ability to fill up. Myocarditis involves inflammation and develops as localized lesions in the heart muscle known as Ashkoff bodies. These Ashkoff bodies can interfere with conduction. In endocarditis, this is the most common problem. We have the valves that are affected, they become edematous, and we have these wart-like vegetations known as varicae that grow on them. The mitral valve or bicuspid valve is affected most frequently. The inflammation disrupts flow of blood and effectiveness of the left ventricle. The valve can be scarred, leading to stenosis or incompetence. Recurrent inflammation is more likely to cause damage to the valves and increase the risk for infective endocarditis. Other sites of inflammation in clients with rheumatic fever include the following: the large joints, especially in the legs. Okay, and this can be involved with synovitis, migratory polyarthritis, where multiple joints are affected. The skin can show a non-pruritic rash known as erythema marginatum, where they develop these red papules or macules that are enlarged and have a white center. Their wrist, their elbows, their knees, and their ankles can have non-tender subcutaneous nodules form. The basal nuclei in the brain, remember we talked about that and how that's responsible for movement, okay, can cause jerky, involuntary movement of the face, the arms, and the legs. For some reason, it's more commonly seen in girls. And this is called as Sydenham Chorea or St. Vitus dance. So that's that involuntary jerky movement of the face, the arms, or the legs. Okay, so signs and symptoms. General indications of systemic inflammation are usually present in acute rheumatic fever. I would know these. So acute rheumatic fever, low-grade fever, leukocytosis, malaise, anorexia, fatigue, tachycardia even at rest, and heart murmurs that indicate the site of inflammation, epistaxis, abdominal pain. Right, so here we're seeing inflammation of the mitral valve, okay? Acute rheumatic mitral valvulitis. And here you see that mitral valve stenosis, right? That mitral or bicuspid valve on the left side of the heart. That mitral valve stenosis, look how narrow that opening is there. So again, general indications of systemic inflammation present in acute rheumatic fever are going to be that low-grade fever, leukocytosis, malaise, anorexia, fatigue, and tachycardia. Also, heart murmurs, okay, can indicate the site of the inflammation. They might have epistaxis and abdominal pain. An acute heart failure may develop from the dysrhythmia or from the severe valve distortion. So here we're going to look for elevated antibody levels after the infection has been eradicated. Heart function tests can be required here. EKG changes can develop. They may develop leukocytosis or anemia. We'll look at the ASO titer, the anti-streptolysin, and that would determine if they had a recent infection by a group A streptococcus. All right, so lifetime prophylactic, antibacterial, and anti-inflammatory agents. All right, so again, we're talking about development of rheumatic fever and rheumatic heart disease and how it progresses. So first you have that antecedent infection, that group A, beta hemolytic streptococcus, like pharyngitis, tonsillitis. Some people recover. Other people, antibodies are going to be formed. This antibody collagen reaction can occur from those antibodies. We'll have inflammation in the heart. Remember, in the heart, those antibodies can be those Ashkoff bodies. Inflammation in the heart, the joints, and the brain, and the skin. All right, we have pericarditis and effusion. We can have endocarditis leading to valve damage. That can cause loss of valve function and arrhythmias. Myocarditis, which can lead to arrhythmias. Development of that scar tissue. Again, that scar tissue is going to cause loss of function, and loss of function arrhythmias. And then eventually the person develops this rheumatic heart disease. Next, we're talking about infective endocarditis, also known as bacterial endocarditis. It occurs in two forms: subacute type, where defective heart valves are invaded by organisms of low virulence. So these could be organisms like that come from the normal floral in your mouth, Streptococcus viridans. Okay? The acute type, the heart valves are attacked by these highly virulent organisms, such as staph A, and this causes severe tissue damage, and it can be hard to treat. Basic effects are the same regardless of what causes it. The microorganisms in the general circulation will attach to the endocardium and invade the heart valves, causing inflammation and vegetation to form. The vegetations are large, okay? They can be masses made up of fibrin. They can be platelets, blood cells, or microbes. In the acute stage, they interfere with the opening and the closing of the valves. pieces can break off of them and form infective or septic emboli that then cause infarction and infection in other tissues. This process causes additional destruction and scarring of the valve and the chordae tendineae. Now, the chordae tendineae holds the valve to the heart. A combination of factors can predispose the person to infection, any abnormal tissue in the heart that develops, microbes in the blood, and the host's ability to fight infection. Abnormal valves associated with predisposing conditions can increase the risk of subacute ineffective endocarditis. These conditions include congenital defects, rheumatic fever, mitral prolapse, and artificial or replacement valves. Anybody with septal defect, a catheter, or other artificial implant is also susceptible to infection. With subacute infective endocarditis, it usually has a slow onset. And usually in the beginning, we'll see a low-grade fever or fatigue. Other manifestations include, again, stuff you need to know: anorexia, enlarged spleen or splenomegaly, Osler's nodes. These are painful red nodules on the fingers. Septic emboli from the vegetations that cause the vascular occlusion or infection, and abscesses in other areas of the body can also cause manifestations, depending on the location of that secondary problem. Release of bacteria in the blood can lead to intermittent increased fever, and congestive heart failure can develop in severe cases. With acute endocarditis, we'll see a sudden onset. The client will have a spiking fever, chills, drowsiness. The heart valves are usually badly damaged, causing severe impairment of the heart's ability to function. Septic emboli can cause infarctions or abscesses in organs, causing additional signs. Following the blood culture and the rapid test to identify the agent, will treat it with some sort of antimicrobial drugs, usually given IV. Pericarditis can be acute or chronic and is often secondary to another condition, either in the heart or the surrounding structures. Pericarditis can be classified by the type of exudate associated with the inflammation. Acute pericarditis may involve simple inflammation of the pericardium, where the rough swollen surfaces cause chest pain and a friction rub, and usually you can hear that with your stethoscope. It sounds like a grating sound on the chest. And effusion can also develop with this condition, and they'll develop a large volume of fluid in that pericardial sac. This can be caused by things like open heart surgery, a myocardial infarction, rheumatic fever, systemic lupus erythematosus, cancer, kidney failure, trauma, or viral infections. So this slide is basically showing you how pericarditis can occur. We have the fluid around the heart that's compressing that heart wall. The heart is not able to expand. We'll see the fluid back up into systemic circulation. There's a decrease in the blood flow to the lungs and a decrease in outflow to the body. Other types of uh, um, fluid that are in the pericardial effusion, it can be serous. So as seen with inflammation, it can be purulent, it can be fibrinous, or it can have blood. All right, so if it was fibrinous and purulent, we'd probably see that in an infection. And then, of course, blood may be some sort of a bleed or some sort of trauma. Also, blood could be associated with cancer. Small volumes of fluid in the pericardium don't really have much of an effect on the heart function, but a large amount of fluid that accumulates rapidly can compress the heart impairing its ability to expand or fill and decreasing the cardiac output, which would result in a condition known as cardiac tamponade. And here the heart can't contract or expand the way it's supposed to. The right side is affected first, and it causes an increased pressure in the systemic veins, and if acute, the person would develop distended neck veins. If fluid accumulates slowly, the heart usually adjusts, and a large amount of fluid can build up before we really start to see signs here. The chest x-ray would show enlargement of the heart. With chronic pericarditis, this results in formation of adhesions between the pericardial membranes that become constrictive, causing the pericardium to become a tight, fibrous enclosure and limiting movement of the heart. The fibrous tissue of the chronic pericarditis often results from tuberculosis or radiation to the mediastinum. Inflammation or infection can result from adjacent structures, for example, pleurisy or pneumonia in the lungs. Effusion can also be secondary to lack of protein or hypoproteinemia resulting from liver or kidney disease. Chronic pericarditis also causes fatigue, weakness, abdominal discomfort due to the systemic venous congestion. Effusion and cardiac tamponade can lead to distended neck veins, faint heart sounds, pulsus paradoxus, in which your systolic blood pressure drops 10 millimeters during inspiration. Next, we will talk about vascular disorders. Hypertension or high blood pressure in both primary and secondary forms is a common problem. Estimates indicate that 1 in 3 adults have high blood pressure, and within this group, 1/3 are undiagnosed and some are not controlled. Another third of the adult population is considered to have pre-hypertension. African Americans have the highest prevalence, the onset is early, and the average blood pressure is higher. Because of the slow onset and mild signs, hypertension is often undiagnosed until complications arise, and therefore it is called the silent killer. Compliance with treatment measures may not occur until a problem is severe enough to interfere with the person's ability to function. Sometimes hypertension is classified as systolic or diastolic depending on the measurement that is elevated. For example, in the elderly, with the loss of elasticity in those arteries, they frequently have a high systolic pressure and a low diastolic value. Hypertension is classified in 3 major categories. I would know those: primary or essential hypertension, secondary hypertension, and malignant or resistant hypertension. In essential hypertension, this develops when the blood pressure is consistently above 140/90. The number can be slightly adjusted for age. The diastolic pressure is important because it indicates the degree of peripheral resistance and an increased workload of the left ventricle. It can be mild, moderate, or severe. In essential hypertension, there is an increase in arteriolar vasoconstriction attributed variously to increased susceptibility to stimuli or increased stimulation, or perhaps a combination. A slight decrease in the diameter of the arterioles causes a major increase in peripheral resistance and reduces the capacity of the system, and increasing the diastolic pressure or afterload substantially. Vasoconstriction leads to decreased blood flow through the kidneys, leading to increased renin and angiotensin and aldosterone secretion. These substances increase vasoconstriction, increase the volume of the blood, and increase the blood pressure. If the cycle is not broken, the blood pressure can continue to increase. Over time, the increased blood pressure causes damage to the arterial walls. They become hard and thick or sclerotic, and the lumen becomes narrow. The wall can dilate or tear and form an aneurysm or encourage atheroma formation. blood supply to the involved area is greatly reduced, leading to ischemia and necrosis, as well as loss of function. Secondary hypertension usually occurs as a result of renal disease or endocrine disease, so things like nephrosclerosis or hyperaldosteronism. It can also be a result of pheochromocytoma, which is a benign tumor of the adrenal medulla, or sympathetic nervous system chain of ganglia. In this type of hypertension, the underlying problem has to be treated in order to reduce the blood pressure. In malignant or resistant hypertension, this is the third type. This is a hypertensive emergency with extremely high blood pressure. This condition usually results in organ damage, including damage to the central nervous system and the kidneys. Diastolic pressure is very high as well, usually. So this slide shows how the hypertension develops. We have some sort of systemic vasoconstriction. We have decreased blood flow to the kidneys. This can be because of nephrosclerosis or some sort of neuropathy. Okay, this causes the kidneys to increase their renin secretion. Okay, that's a vasoconstrictor. It's also going to trigger aldosterone to be released. Okay, so we have a vasoconstrictor. Now we have aldosterone causing us to retain more sodium and fluid. This is going to increase that blood pressure. We're going to see damage to the kidney vessels, those delicate small vessels, increased workload for the heart, which can lead to left-sided congestive heart failure, damage to the cerebral arteries, leading to a stroke. It can cause damage to the arterial walls, leading to atherosclerosis, and it can also damage those little vessels in the eyes, causing retinal damage and blindness. So the areas most frequently damaged by the elevated blood pressure are going to be the kidneys, the brain, and the retina or the retinal blood vessels. Okay, we can easily look at these for sclerotic changes and rupture. The result of poorly controlled high blood pressure can be chronic renal failure, stroke because of hemorrhage, loss of vision, or congestive heart failure. Your lifespan can be considerably shorter or reduced, especially in men, if the hypertension is not controlled well. Incidence can increase with age. African Americans have a higher incident. The retinal blood vessels can be easily observed for sclerotic changes and rupture again. Okay, so we don't want to shorten our lifespan. We want to make sure that we're controlling that blood pressure and that we're taking the necessary moves to do that. So, are we monitoring our sodium intake, our alcohol intake, making sure we're not obese, stop smoking, and trying to reduce our stress as much as we can. If the client doesn't feel bad or if nothing's happening, okay, it can be hard for them to be compliant. The result of the poorly controlled high blood pressure, again, can lead to things like kidney failure, stroke, hemorrhage, loss of vision, or congestive heart failure. So, clients need to be aware of this and need to really, work on trying to keep that pressure under control. Hypertension is frequently asymptomatic in the early stages, giving it that silent killer label. The initial signs are often vague and non-specific. Okay, but if they do have signs, then these are what they might feel: fatigue, malaise, morning headache. Consistently elevated blood pressure under various conditions is the key sign. Complications are also asymptomatic, often until they are well advanced. So, treatments, again, you're not being tested on this, but we're looking at lifestyle changes, weight loss, reducing salt, reducing stress, and then drugs if we need to. Next, we're talking about shock or hypotension, and this comes from decreased blood volume in the circulation system, leading to decreases in the amount of tissue and organs perfused and general hypoxia. In most cases, our cardiac output is low. Hypovolemic shock can be caused by loss of blood, plasma, hemorrhagic issues, burns, dehydration, peritonitis, or pancreatitis. With cardiogenic, usually we have some sort of myocardial infarction of the left ventricle or cardiac arrhythmia, and this decreases the pumping capability of the heart. It can also be seen with pulmonary embolism and also cardiac tamponade, like we discussed with severe pericarditis, where the heart's not able to contract and expand. Vasogenic or neurogenic shock or distributive shock. This is vasodilation due to loss of sympathetic and vasomotor tone. We'll usually see this with spinal cord injuries, but we can also see it in hypoglycemia or insulin shock and with people experiencing severe pain and fear. Anaphylactic shock. This is where we have systemic vasodilation and increased permeability due to severe allergic reactions, insect stings, drugs, nuts, or shellfish. And then septic endotoxic shock, where we have vasodilation due to severe infection with the gram-negative bacteria, virulent microorganisms that are gram-negative or multiple infections. I would know what these different types of shocks are and what causes each one. Also know the signs and symptoms. In clients with shock, there's usually less cardiac output. So that means less blood into the circulation system. Okay? This causes a reduction in oxygen and nutrients for the cell. Because we don't have enough oxygen, the body goes into anaerobic metabolism, and that's going to increase our lactic acid production. The client can present with things like anxiety, tachycardia, pallor, lightheadedness, syncope, sweating, oliguria. I would review this chart. I would know what the manifestations of shock are. How does the body compensate? Okay. What causes different types of shock? And as a person moves into progressive shock, their chances of survival now become very small. So we don't want our client to get there. We hope that we catch this in the early stages and that we're able to reverse whatever's going on through treatment, okay? But progressive shock is bad. Once they get to progressive shock, there's a very small chance of survival here. So as soon as our blood pressure drops, our compensation mechanisms should kick in. The sympathetic nervous system and the adrenal medulla are stimulated to increase the heart rate, the force of contractions, and vasoconstriction. Renin is then going to be secreted because the kidneys recognize there's not enough flow coming there, and that will activate angiotensin, a vasoconstrictor, very powerful one. All right, and then aldosterone will also be triggered here to help us reabsorb sodium and water. The body will also increase the secretion of antidiuretic hormone. That will allow us to conserve fluid. So it will promote reabsorption of water from the kidneys to increase the blood volume, and it will also act as a vasoconstrictor. Glucocorticoids would be secreted to help stabilize the vascular system. The acidosis in the body is going to stimulate our respirations and increase the oxygen and reduce the carbon dioxide level. If an organ is the source of the problem, it cannot compensate for the problem. So like if I'm having an MI and I go into cardiac shock or cardiogenic shock, okay, the heart is not going to be able to help me compensate. All right, so cardiogenic shock cannot be compensated for by increased cardiac output. If shock is prolonged, the cell metabolism is diminished and the cell wastes are not removed. This would lower the pH or lead to acidosis, and that's going to impair the cell enzyme function. Acidosis also will cause vasodilation and relaxes the precapillary sphincters, contributing to more pooling of the blood in the periphery and decreasing the amount of blood returning to the heart. If the shock is not reversed quickly, it becomes harder and harder to treat and reverse because the compensation and effects of shock will aggravate the problem. Vasoconstriction reduces arterial blood flow to the tissues and the organs, and this causes ischemia and eventually necrosis. So if you've ever seen somebody with septic shock, some of them lose fingers and toes. Thrombi will form in the microcirculation system. So your client's going to develop DIC, disseminated intravascular coagulation. The body's going to run out of clotting factors, and they'll start to bleed from little wounds, their nose, any openings in the body. Okay, and this is going to contribute also to the venous return by reducing the cardiac output. Fluid shifts from the blood into the interstitial fluid as more cytokines are released from the damaged cells, and the organs and tissues can no longer function or undergo mitosis. When the organ damage occurs, the shock may be irreversible. And we have to worry about multiple organ failure here, known as MODS, okay? And this can happen even if the patient appears to be stabilized. Decompensation causes complications of shock, such as acute renal failure because of tubular necrosis, the shocked lung or acute respiratory distress because of pooling of the blood and alveolar damage, liver failure or hepatic failure because of cell necrosis, paralytic ileus and stress due or hemorrhagic ulcers, infection or septicemia from the digestive tract, ischemia, or from the primary problem of the septic shock. Primarily endotoxic shock has a higher mortality rate because toxins can depress your myocardial function and ARDS and activate the coagulation process. So disseminated intravascular coagulation as the clotting process is initiated. Then depression of cardiac function by the oxygen deficit, acidosis, the hyperkalemia, and the myocardial depressant factor released from the ischemic pancreas. Eventually, cardiac arrhythmias and ischemia develop, and this can all lead to cardiac arrest. But multiple organ failure, shock becomes irreversible, and death can occur. Often missed, the first signs of shock are usually thirst, agitation, or restlessness because the sympathetic nervous system is quickly stimulated by the hypotension. Then this is followed by the characteristic signs of compensation, which are going to be that cool, moist skin, cool, moist pale skin as the body tries to compensate right here. Tachycardia, vasoconstriction, shunting the blood from the organs and the skin to those vital areas. In cases of septic shock, the client can experience warm shock with the following symptoms. I would know this. This is a different effect here. So they'll have fever, they'll have warm, dry, flushed skin, a rapid, strong pulse, hyperventilation, evidence of some infection. And then the direct effects of a decrease in the blood pressure and the blood flow become manifested by lethargy, weakness, dizziness, a weak, thready pulse, initially hypoxemia and respiratory alkalosis as respirations increase, and then acidosis or a low pH due to anaerobic metabolism. And so here we have our patient compensating with these increased respirations as the shock gets worse. Okay, the metabolic acidosis will dominate. If shock is prolonged, the body's responsiveness will decrease as the oxygen supplies dwindle and the waste accumulate in the body. Prognosis is good in the early stages, but the mortality rate increases as decompensated shock develops in conjunction with kidney failure, ARDS, or disseminated intravascular coagulation. That concludes this lecture.